those of you that don't know me, my name's Kate Steiner. I'm an interventional radiologist here in the UK. It's my pleasure to present the interim 24-month data from the Lutonix IDE trial. This is a podium first, the first time that this data has been presented. The objective of the Lutonix IDE clinical trial was to assess the safety and the efficacy of the Lutonix 035 drug-coated balloon PTA catheter in the treatment of dysfunctional native arteriovenous fistulas. 285 patients were randomized across 23 sites. The primary effectiveness endpoint was target lesion primary patency at 6 months, and the primary safety endpoint was freedom from any serious adverse event over 30 days. Follow-up was clinically driven at the shown intervals. The first subject was enrolled in June 2015, and enrollment was really rapid. This trial completed the next year in March 2016. Key inclusion criteria were the patient had to be an adult with an upper extremity fistula with either clinical or dialysis parameters which indicated a dysfunctional AV access. The fistula had to be mature and used for at least one session with 2 needles, and the patient had to be catheter-free for 30 days to be included. The angiographic criteria included a successful pre-dilatation, and we'll come back to that when we look at the study design, with a reference vessel diameter between 4 and 12 millimeters, reflecting the sizes of the Lutonix catheter. Exclusion criteria were any lower extremity access, any lesion central to the thoracic inlet. Any access was thrombosed at the time of intervention, but access that had had a previous thrombotic event could still be included in the study. There was a maximum of 2 lesions within the circuit. Secondary non-target lesions had to be successfully treated to be included, and bare or covered stents could be included in the access circuit, but they couldn't be part of either a primary or a secondary target lesion. This is the study design. The non-target lesion had to be treated first with a good, successful PTA with a less than 30% residual stenosis. Then pre-dilatation of the target lesion was performed here with PTA. PTA had to be a good PTA with a residual stenosis of less than 30% and complete effacement of the waist of the balloon with no clinically significant dissection or extravasation. The patient was then randomized in a 1-to-1 fashion and enrolled in the study with either treatment with Lutonix or treatment with an equivalent compliant balloon. Pre-dilatation was on a 1-to-1 basis regarding sizing of the pre-dilatation and treatment balloon, and follow-up was clinically driven and shown here. The key demographics are matched between both groups, and this difference in peripheral arterial disease was not statistically significant. The fistula locations, predominantly 2/3 were in the upper arm with 1/3 within the forearm, reflecting a North American population. And a wide variety of lesions were included in the study, and lesions were matched within both groups, including inflow lesions proximal to the cannulation segment, outflow lesions distal to the cannulation segment, and cephalic arch lesions at about 20%. These were the lesions making up the bulk of the study, but a wide variety of lesions were included. Reflecting our clinical practice, about 2/3 of lesions were restenotic lesions, with only 1/3 being primary de novo lesions. The primary safety point was met at freedom of SAEs involving the access circuit at 30 days, and treatment was non-inferior to PTA. So these are the patency curves now running out to 24 months. And we can see that the curves remain separated over the 24-month period. They start to separate here about the 90 to 100-day mark, and then remain separated out to 550 days where there's a 36.8% improvement in target lesion primary patency and a 30% improvement at 730 days. I think it's the fact that the curves are separated over such a long time period which is interesting. At no point do they come to meet or cross, which is what we would probably start to expect going out to 24 months. When we look at all the patients now within the study over a 24-month period, we see that patients within the Lutonix DCB group went on average for 11 months or 318 days before intervention to the target lesion, compared with patients in the control group who went on average 7 months or 198 days before treatment to the target lesion, resulting in 120 more re-intervention-free days. There's a difference of about 4 months between the groups. So for a patient who has to come to the dialysis unit 3 times a week, this may be significant. And also patients don't necessarily understand target lesion primary patency rates, but they do understand intervention-free days. This is a case, not from the study, but a case from our institution where we've used the Lutonix PTA balloon successfully. It was a patient who had initial PTA for a poorly maturing fistula and poor flow. The fistula was then used, but there were still problems with poor flow and cannulation. A duplex demonstrated a restenosis. They had a repeat treatment using the Lutonix and then went for 15 months before they needed subsequent angioplasty. This is the lesion. We selected this lesion for treatment with Lutonix based on the ultrasound appearances here of neo-intimal hyperplasia. This is a pre-procedural ultrasound. This is post 8 weeks out, where there's perhaps a little intimal flap here, but it hasn't recurred as yet. This was a radiocephalic fistula. Here's the stenosis within the cephalic vein, pre and post-treatment. And then this is the recurrent lesion, which happens in this patient to be of a different appearance with no measurable intimal hyperplasia. So the Lutonix IDE trial is now the first large level 1 multi-center trial for looking at DCBs in dysfunctional AV access. There's a sustained effectiveness through 24 months where the lines don't meet and they don't cross, which was not necessarily what we would expect. When we look at all the data now over 24 months, there's an average of 4 months more re-intervention-free days for the patients within the Lutonix group. This trial, together with the global registry, which we had the results presented, preliminary results presented by Dr. Kitru yesterday, and the post-approval study, when all subjects are involved in the post-approval, there'll be over 800 patients going towards addressing the data deficit with dialysis intervention. And I predict, as we learn more about the pathophysiology of these stenotic lesions and what we're treating, we will see even more innovation in this area. Thank you very much.